emergency room. But you see, the challenge happens when someone is pregnant and come with a stroke with different comorbid factors. So that's the reason I chosen the topic, how to approach and how to manage the arterial stroke during pregnancy time. The pregnant or recently pregnant women develop stroke, that is 30 per 100,000 pregnancies, more frequently than their non-pregnant counterparts. So pregnancy has an increased risk for stroke. So it's very important that we should keep a vigilance on these patients, and when something new neurologically happens, we have to keep an eye that these people are more prone for stroke compared to the non-pregnant women. Data from a population-based registry in Finland suggests that the incidence of stroke during pregnancy or puerperium has increased over time. So, if you take the time period also compared to the past years and the present years, and then the incidence of stroke has increased because of so many reasons: the diet pattern, the lifestyle, and so many reasons has increased the incidence of stroke over the period of years. In addition to the pregnant women, also prone for more stroke chance compared to the non-pregnant women. 10% of strokes occur in the antepartum period, 40% proximate to the delivery, and 50% occur in the postpartum and after discharge. So it's very, very important that as soon as the delivery happens, that's a period that the vigilance should be more, so that we should not miss the stroke happening into these people. If we take the cerebral venous thrombosis or stroke, and the postpartum period is a very important period, and so it's very important to observe this patient, not to discharge immediately if we suspect something, to keep an eye on these people for a few days before we discharge the patient, because the incidence is almost 50% in the postpartum period. If we take the cerebral infarction, the relative risk was 0.7% during pregnancy, which increased to 8.7% in the postpartum period. So even if among the pregnancy period and compared to the postpartum period, the incidence increased many-fold in the postpartum period. For intracerebral hemorrhage, adjusted relative risk was 2.5 during pregnancy, which increased to 28.3% in the postpartum period. So if you take the bleeding, venous thrombosis or arterial infarction, everything, the chance is very high in the postpartum period. What are the physiologic and pathophysiologic alterations happen in these patients? Changes in the cardiovascular hemodynamics, coagulation factors, hemoconcentration, endothelial dysfunction, inflammation, and impaired cerebrovascular tone. There are so many things happen, physiological changes in the pregnant woman, which makes them to prone for stroke during pregnancy in the postpartum period. Cesarean delivery, gestational hypertension, and peripartum infection also contribute to the chance of stroke in the pregnant women. Other risk factors for risk during pregnancy are hypertension, like regular people, hypertension, smoking, antiphospholipid antibody syndrome, inherited thrombophilia, arterial disease, certain types of heart disease, hyperlipidemia, paradoxical emboli, arterial dissection, substance abuse, age over 35 years, migraine with ARA, and from black population. These are all the general risk factors, which are also a risk factor for the pregnant woman if they possess all these risk factors. So they are separate risk factors due to the pregnancy-induced physiological and pathological changes, along with the regular risk factors like any other people in the population. Complication during pregnancy presenting as stroke or stroke-like event. There are some other disorders which happens during pregnancy which also contribute to stroke or can present like stroke, like preeclampsia, eclampsia, and HELP syndrome, reversible cerebral vasoconstriction syndrome, postpartum cerebral angiopathy, and cerebral venous thrombosis. So these are all the special types of reasons where people can have stroke during pregnancy in the postpartum periods, apart from the arterial stroke. And these are the reasons for other arterial changes in the pregnancy in the postpartum period, which are specific for pregnancy. Hypercoagulable state, peripartum cardiomyopathy, amniotic fluid embolism, gestational trophoblastic diseases. These are the other reasons for stroke during pregnancy time. MRI is safe during all trimesters of pregnancy, but to avoid gadolinium. MRI is more sensitive in detecting early infarction, cerebral venous thrombosis, and structural lesions. Reversible posterior leukoencephalopathy syndrome, better depicted by MRI using fluid attenuated inversion recovery sequences. So MRI is better and avoid gadolinium. Hypercoagulable testing. So if you take the testing for inherited thrombophilia, it can be done anytime. That is molecular genetic testing like antithrombin deficiency, prothrombin G20210A, factor V laden, protein S and C deficiency. It can be done anytime. Suppose if you see a stroke and if you are suspecting inherited thrombophilia, this test can be done immediately. You don't need to wait for some time before doing the test. But patients who are pregnant or recently pregnant, non-molecular laboratory testing, that is a molecular genetic test, this is a non-molecular laboratory testing like activated protein C resistance ratio, functional assay for protein C, free protein S antigen assay, antithrombin apparent cofactor assay, ideally should be delayed until 3 months or more following delivery. So if you do during the immediate period, the test may be giving a spurious result. It may not be there and giving the right result for you. In 2019, American Heart Association and American Stroke Association guidelines, IV alteplase administration may be considered in pregnancy when the anticipated benefits of treating moderate or severe stroke outweigh the increased risk of uterine bleeding. Eligible patients should be treated as quickly as possible within the appropriate 3 or 4.5-hour time limit after careful discussion of the potential risk and benefit with the patients and the attendants. The prescribing label for alteplase does not list pregnancy as a contraindication, but states that the risk of therapy may be increased in pregnancy. Potential risks include the maternal hemorrhage with thrombolysis, possibly resulting in premature labor, placental abruption, or fetal demise. Hemorrhage during parturition or cesarean delivery is a particular risk with thrombolytic therapy. The patient goes into labor or operative delivery is required. Based on its molecular weight, alteplase is not expected to cross the placenta. It is unknown if alteplase is present in the breast milk. There are no data recording teratogenicity in humans, but no such risk was found in the animal studies. Endovascular treatment options like particularly mechanical thrombectomy may be preferred over IV thrombolytic therapy for women considered to have a high risk of hemorrhage, such as those with placenta previa or history of obstetric hemorrhage. These interventions should be attempted only at centers with appropriate expertise. One report evaluating stroke registry data found that the use of acute reperfusion therapy in pregnant or postpartum women was associated with outcomes that were similar to those in non-pregnant women. That study included 338 pregnant or postpartum women and over 24,000 non-pregnant women ages 18 to 44 years with ischemic stroke. So quite large amount of non-pregnant women and 338 pregnant women or postpartum women. Acute reperfusion therapy was defined as IV TPA catheter-based thrombolysis or thrombectomy or any combination of these interventions. Those treated with acute reperfusion therapy, there was no difference between pregnant or postpartum women and non-pregnant women for rates of in-hospital death, that is 2.1 versus 2.7%. So there is no increase in the mortality. Discharge to home was 75 versus 73%, more or less same. Or independent ambulation at home was 74 versus 71%. So they done exactly more or less same. There was a higher rate of symptomatic intracranial hemorrhage in pregnant or postpartum women, 7.5% compared with the non-pregnant women of 2.6%. The difference did not achieve statistical significance, although it was limited by small numbers of patients, because as I was telling, that was 338 versus 24,000. Another analysis of female patients with acute ischemic stroke from the national inpatient sample identified 180 pregnant or postpartum women treated with mechanical thrombectomy compared with over 48,000 non-pregnant female patients treated with mechanical thrombectomy. Pregnant and postpartum patients had lower rates of both intracranial hemorrhage, 11 versus 24%, and poor functional outcome, 50 versus 72%. So sometimes you see the data, some other data may totally differ, but the overall thing is they're more or less done same thing, and there are some special risk with these people, and the number is not exactly comparable because 180 versus 48,000, that is 338 versus 24,000. Yearly aspirin therapy is recommended for patients with acute ischemic stroke who are not receiving full dose of anticoagulation. Aspirin may also be used in combination with subcutaneous heparin for DVT prophylaxis. Do not routinely use clopidogrel or any regimen of dual antiplatelet therapy to treat ischemic stroke or transient ischemic attack in pregnant population. 2012 American College of Chest Physician guidelines recommended low molecular heparin instead of unfractional heparin for the prevention and treatment of venous thromboembolism during pregnancy. ACCP guidelines recommend discontinuation of low molecular heparin or unfractionated heparin at least 24 hours before induction of labor, cesarean delivery, or expected time of neuroaxial anesthesia. Concerns for different types of anticoagulation during pregnancy. Warfarin is potentially teratogenic when given between 6th and 9th weeks of gestation. In addition, when given in the second and third trimester, warfarin can lead to central nervous system abnormalities that are thought to be due to repeated cerebral microhemorrhages. Heparin does not cross the placenta and therefore it is not teratogenic and does not anticoagulate the fetus. Concerns with heparin therapy include the relative difficulty of maintaining a stable therapeutic response, the inconvenience of parenteral administration, and the complications of heparin-induced thrombocytopenia and bone demineralization, which can lead to fractures in patients treated for more than 6 months period. Low molecular heparin does not cross the placenta. Compared with unfractionated heparin, low molecular heparin has the advantages of producing a more predictable anticoagulant response to fixed doses administered once or twice daily and is less likely to produce thrombocytopenia or possibly bone demineralization. If you take the breastfeeding, the small fraction of iodinated or gadolinium contrast agent is secreted in the maternal milk. That's very important. Suppose there is another option, people want to give gadolinium. Keep in mind that especially postpartum period, the baby has come out. So if you want to give that small fraction of this is secreted in the maternal milk. Women who require neurovascular imaging should discontinue the breastfeeding for 24 hours after receiving IV contrast media and discard the milk expressed during that interval before receiving normal breastfeeding. They should not only stop the feeding for 24 hours, they should express the milk and discard the milk before start feeding the baby after 24 hours. There are no contraindications to breastfeeding while being treated with unfractionated heparin or low molecular heparin. Nursing mothers can safely take warfarin because there is no convincing evidence that warfarin exerts an anticoagulant effect on the breastfed infant. So that is the end of the talk. And I just covered the important aspects of arterial stroke during pregnancy. A lot of things about the CVT and all these reversible vasoconstrictions. I don't want to get into too much of information. Just want to cover the important information because the time period is very important to finish the talk. So anything we can discuss later in the discussion time. And my talk is over. I will hand over the mic to the chairpersons and for the next speaker. Thank you very much.
Thanks, Professor PAZHANI, for